Sure. So it's a pleasure to introduce Celline to everyone, although I think people probably know her. She's been with us for a couple of years. Um, she in her training initially in pharmacy. She's a pharmacist, and her PhD were in Brazil, her country of origin, but she's been here doing a postdoc with us for as I mentioned a couple of years now. And I'll say that one thing about Celline, I think that is an overarching theme across all of her work, her PhD and the postdoctoral work she's doing, is that she's someone who's really focused on providing access to safe and effective medications uh, for all people, including even the most vulnerable. So if you look across her work, you'll see how in different ways she's tried to answer to that need. And I would say another really theme of her work is engagement and making her work relevant for decision makers and stakeholders that need that information. So today she's going to talk to us about an exciting project that is actually funded by CHR through a project grant. So Celline, take it away.
Thank you, Sasha, for the introduction, and thank you everyone for attending this session. So the title of my presentation is Towards Personalized Treatment of Complex Chronic Diseases using hydroxychloroquine in lupus as an example. So as Sasha mentioned, I'm a postdoctoral fellow here at the core, and I'm in the third year of my postdoctoral fellowship. So I have no conflicts of interest to declare. As Sasha mentioned, this project, the project I'm going to talk about later, it's funded by CHR, and I received funding from FRQS, DSECT, and the RIMUHC. And so as an outline, I will briefly define personalized treatment, and later I will talk about the approaches commonly used, giving description, example, and limitations of each of them. And then I will present the main steps that we are following to provide personalized treatment for patients with systemic lupus using hydroxychloroquine. So this figure shows the percentage of patients for whom a major drug is effective in average. And this supports the inefficacy of the approach of one dose fits all. Because as you can see, from 38% to 75% of patients with different conditions fail to respond to a treatment. And personalized treatment, it's basically the same as personalized medicine or precision medicine, but more focused on pharmacological treatment. It tries to evaluate which treatment strategies work better in which subgroups of people. And it's similar to what we do for blood transfusion. So a recipient is not giving blood from a randomly selected donor. Instead, the donor's blood type is matched to the recipient to reduce the risk of complications. So you can think of personalized treatment as something similar. And there are three main methodological approaches towards personalized treatment. And I'm going to explain two of them better in the next slides. But the most well-known method is pharmacogenomics. But clinical reality spans multiple dimensions, so clinical information and patient's preference could also be used to extract evidence to promote personalized treatment. Pharmacogenomics is the use of genetic testing to guide drug treatment. It's the customization of medical treatment to an individual genetic profile, and it's what they call tailored treatment. And a well-known example of pharmacogenomics is the use of abacavir in people living with HIV. So abacavir is a good antiretroviral agent, but it's associated with the hypersensitivity syndrome, which causes combinations of fever, rash, diarrhea, nausea. And the syndrome is the main reason for drug discontinuation among people using this drug. And previous studies suggested strong associations between clinical diagnosis of the syndrome and the variant of the HLA gene complex. And then Phillips and others observed that the presence of this variant was associated with a 50% likelihood of a hypersensitivity reaction. So the standard of practice now calls for genetic testing prior to the use of abacavir, with use of an alternative drug if the test is positive. So this is a successful example of pharmacogenomics being feasibly implemented in the clinical setting to prevent a previously unpredictable toxicity of a specific drug. However, some limitations should be mentioned. Personalization based exclusively on biomarkers such as genomic factors fails to account for many other important elements of patient care. And currently, genetic profile guides therapy for only a small minority of patients, in the sense that some diseases like lupus, it can offer guidance. And even in the example I just gave, the variant responsible is present in only 8% or less of the population. Also, this is an expensive intervention, so it contributes for health inequality, since it's a benefit unavailable to people who lack access to quality healthcare. Based on a patient's clinical information, we could evaluate whether treatment effects vary over identifiable patient characteristics, such as demographic, lifestyle, and clinical characteristics. And so we would group individual patients in subpopulations according to the probability to have a therapeutic benefit or toxicity from a treatment strategy. And here's an example of the use of methylphenidate in children and adolescents with attention deficit hyperactivity disorder, ADHD. And although methylphenidate is a well-known treatment for ADHD, 35% of patients are non-respondents to the treatment. So a cohort study in Spain aimed to identify objective, clinical, or biological markers that can predict response to this drug. And the results suggest that the non-responder profile included patients with oppositional defiant disorder, depressive symptoms, alcohol or cannabis use, and high ADHD severity. So the recommendation for clinical practice is to detect these characteristics in the first clinical interview and consider prescribing other stimulants or non-stimulants if the patient fits this non-responder profile. And one limitation of this type of approach is the limited quantity and quality of available evidence. So the prediction model is limited to the variables available in the data set and to the sample used. Also, the risk prediction model will not remove uncertainty from clinical decision-making, nor replace the need to incorporate patients' preferences, which is our next approach. So the individualization of treatment requires patients' perspectives, values, preferences, and experiences to be considered. In this case, patients are actively involved in their care, and healthcare providers treat the whole person, not just their disease. An example of a study that used this approach investigated patients' preferences regarding warfarin to prevent strokes. Since evidence exists regarding underuse of warfarin, so less than 40% of patients with atrial fibrillation use anticoagulation. So a semi-qualitative study where older patients with atrial fibrillation were given information on the benefits of warfarin on stroke against its risk of causing cerebral hemorrhage. So patients were given this information and then asked if they would prefer using warfarin or placebo. And the major themes in formulating these decisions included personal beliefs, alcohol cessation, past experience of stroke, and others' experience of stroke or hemorrhage. So for instance, some patients would prefer taking warfarin because a friend just had a stroke and wasn't using it. Or some patients would decline the use because a family member recently had a cerebral hemorrhage after using warfarin. Then the recommendation for practice was to carefully listen to the views and reasoning of patients in response to both short-term and long-term risk information to make better and more informed choices. And a limitation is that preferences of patients may focus on social or lifestyle choices more than ultimate medical outcomes. So for example, a patient may forego a current treatment that interferes with work goals, even though the treatment would prevent later disability. And preference may vary with time and circumstances. Again, risk perception is higher when the patient is not feeling well. And it's also been shown that patients have difficulties in understanding verbal expression of risk. So an accurate assessment of preferences can be challenging. It depends on communication styles, trust in the provider, and we need education for both provider and patient. And of course, all approaches have their strengths and limitations, and that's why combining two or more would be a good strategy. Let's leave us to an example of our research project of hydroxychloroquine in lupus. Lupus is an autoimmune disease that can affect any organ and potentially leads to irreversible damage. It affects up to 5 million people worldwide and 1,500 in Canada. 90% are women, and peak incidence occurs in working age individuals. And it's 2 to 3 times more common in minorities, being a leading cause of death among African Americans and Hispanic young women. And it is important to highlight here that lupus is a lifelong disease that usually will not stay in remission without drugs. And lack of control will lead to damage of organs, especially kidney, and severe lupus can lead to fulminant inflammation and death. And the cornerstone treatment for lupus is hydroxychloroquine. It is a drug that is used by every single rheumatologist in North America, and it greatly reduces lupus flares. But if you get lupus at age of 18, which is very common, you could need drugs for 70 years. And the long-term use is associated, especially over 10 to 20 years, is associated with retinal toxicity, which is a serious and irreversible condition that may evolve to vision loss. And physicians have no idea when or whether to reduce, stop, or maintain hydroxychloroquine. Some patients may do well after tapering or discontinuing the drug, but others will have potentially life-threatening outcomes. Clearly, we need better predictors of flare risk and future risk for retinal toxicity in order to balance the risks and benefits of hydroxychloroquine. So our overall goal is to understand the risks and benefits of hydroxychloroquine use to provide personalized treatment for lupus patients. And the first aim is to identify predictors of a flare after hydroxychloroquine is tapered or discontinued. The second is to evaluate the temporal relationship between hydroxychloroquine and retinal toxicity and also identify the predictors. The third is to assess lupus patients' preferences for hydroxychloroquine therapy. And the fourth is to test our findings in clinical practice. So here I just organized the 4 aims into 4 steps. And the first step is to find the subgroups at risk of flares after hydroxychloroquine is tapered or discontinued. And we used the Canadian clinical cohort, which included 5 cities: Calgary, Winnipeg, Quebec, Montreal, and Halifax. And after cohort enrollment, which started in 1999, we selected all patients using hydroxychloroquine. And at the follow-up visit, which occurred annually, we identified the first discontinuation, first dose reduction, or patients who maintain hydroxychloroquine. And for those, we matched the index date on length of hydroxychloroquine use. And they were right sensor if they either reduced or discontinued therapy as they entered the other groups. And the same thing happened with patients who reduced hydroxychloroquine, but then discontinued the therapy later on. And otherwise, patients were followed to the occurrence of the outcome, death, or at the end of the study. And our outcome was time to first flare, which could be hospitalization due to lupus, increase in disease activity, or therapy augmentation. We then calculated the crude flare rates and identified the baseline predictors of a flare using Cox regression. We included 1,300 patients using hydroxychloroquine. The majority was female and Caucasian. And here's the distribution in each exposure group, remembering that the same patient could contribute per time in all three groups. And by evaluating their crude flare rates per 100 years, you can see that patients who remained on hydroxychloroquine, they had lower flare rates per 100 years than those reducing or discontinuing. That's almost half the flare rate. And for the Cox regression, we separated you got 3 separated Cox regressions for each group. And the risk of flaring after tapering hydroxychloroquine was higher, mainly for people using prednisone at the moment they were tapering the dose. For those discontinuing, we observed higher risks for Black patients and those who were younger than 25 years old at the lupus diagnosis. And even for those maintaining hydroxychloroquine, we observed higher risks for First Nation patients and those using immunosuppressors. We recently replicated this study using an international inception cohort, but this paper is not submitted yet, so we will only present the results that were presented before in scientific meetings. So we used the Systemic Lupus Erythematosus International Collaborating Clinics Inception cohort. It's from the SLICC group. It enrolls patients with up to 15 months of diagnosis, so they're incident cases of lupus, from 33 centers in 11 countries around the world. And we included 1,460 patients on hydroxychloroquine, again, majority female and Caucasian, though the percentage of Caucasian is a bit lower than the Canadian cohort. And again, the same patient could contribute to 1, 2, or 3 groups. Here we can see the same pattern, the flare rates. So patients who remained on hydroxychloroquine had significantly lower flare rates than those reducing or discontinuing. And we observe slightly higher flare rates here in this SLICC cohort, which makes sense since it's an inception cohort compared to the Canadian, which was a prevalent cohort. And here patients may be earlier in disease when flares may be more likely to happen. And this is the overall Cox regression, so it's not separated by group. And we're actually comparing the groups directly. And we observed that the reduction and discontinuation groups had higher risks than compared to the maintenance group. And we also observe clear predictors for patients who were in Asian geographical location and prednisone and immunosuppressors use as well. So in summary, patients reducing or discontinuing hydroxychloroquine are at greater risk of having a poor outcome versus those maintaining hydroxychloroquine. And particularly Black patients, those who are younger at lupus onset, and those using prednisone, which is a marker of more severe lupus, have more flares after hydroxychloroquine tapering or discontinuation. And being aware of these factors may help physicians and patients in personalizing decisions regarding hydroxychloroquine de-escalation or maintenance. And for potential limitations, this is observational data, and these analyses do not account for the reasons why hydroxychloroquine was reduced or discontinued. But when replicating the analysis with the SLICC cohort, we explored some of these potential reasons, such as clinical remission, changing guidelines, and retinal damage. And then the reminder, we assume the reasons included non-adherence or drug intolerance. And now the second step was to evaluate the time relationship of hydroxychloroquine and retinal toxicity and to identify the subgroups at risk. Again, we used the SLICC inception cohort. And here we just use this cohort because we wanted to follow patients since the beginning of their hydroxychloroquine treatment. So from the first visit where they receive hydroxychloroquine, we follow them until the occurrence of the outcome or death or end of study. In the outcome was retinal damage, which we picked up from the SLICC damage index, and then we confirm with chart reveal to see if it was induced by hydroxychloroquine. We then constructed a Kaplan-Meier curve and conducted Cox regression to identify the predictors. So it's the same populations before, 1,300 patients. The mean follow-up was 7 years, and the incidence of retinal toxicity was 1 per 1,000 person years. Only 11 patients had retinal toxicity within the time we evaluated. And mean duration of hydroxychloroquine therapy in the cases was 9 years. No cases of retinal toxicity was detected in the first 5 years of therapy. And here in the Kaplan-Meier curve, you can see that the probability of retinal toxicity was up to 1%, up to 10 years of cumulative use of hydroxychloroquine, and increases around 1% each year after that, reaching 5% after 15 years of cumulative time. And here's the results for the Cox regression. Since the outcome was rare, we had low power to identify the factors associated with retinal toxicity. We could see some trends for Black patients, those who were older at diagnosis, and overweight patients. In summary, we didn't see any case of retinopathy within the first 5 years of hydroxychloroquine use, which is reassuring to patients starting hydroxychloroquine and their physicians. And most people on hydroxychloroquine don't develop retinal toxicity even after 17 years. It was the maximum of cumulative use we had. But we need more work to identify the vulnerable subsets. And here I highlight the ones that agree with the literature and have biological plausibility. So for instance, for those who were older at onset, there is significant loss of retinal neurons between 20 and 40 years of age. Patients with higher BMI probably receive higher hydroxychloroquine doses, since current guidelines recommended those to be calculated based on their weight. And for Black patients, it is known that hydroxychloroquine accumulates on the melanin pigment, which is in higher concentration in people of dark skin color. And patients' preferences is our next phase. We are currently conducting qualitative interviews in Montreal and Calgary centers. And we are asking patients their preferences regarding hydroxychloroquine, their thoughts and concerns around reducing or stopping treatment, which may include the fears of flare, impact of duration, severity of the flare, and how a flare would be managed. We also ask if they had experience, if they have ever lowered or discontinued hydroxychloroquine and the factors behind these choices, and their preferred approach for those lowering and discontinuation. And then based on the identification of the predictors and the qualitative results, we will construct a discrete choice survey, which will present different sets of treatment options, and each option will be described by specific attributes such as dose, duration, risk of flares, risk of toxicity. And then we can explore which treatment options are preferred by the majority of patients, and also understand whether different patient subgroups prefer different treatment strategies. And as the last step, we want to test our findings in clinical practice by leading a pragmatic trial. And we're still walking on baby steps here, but a simplistic representation would be to randomize patients and their physicians to either receive routine care, which would be the control. So physicians here wouldn't know anything about our study, our results actually. And then the intervention group would based on their preferences and the subgroup of patients, they would either maintain the therapy or de-escalate the dose. And here we would have more subgroups of different strategies to de-escalate the drug. This is a testimony of a patient with a partner in our research, and she has lupus since she was 11, and now she has retinal damage, and it has already impaired her vision to a point she cannot drive anymore at night. And she said, understanding how to take hydroxychloroquine and when and how to stop it is vital. Being a patient with retinal damage caused by hydroxychloroquine, I can't stress enough how important this research is. And so just to recapitulate, the goals of personalizing treatment is to ensure effectiveness and safety, improve quality of life, and avoid over-treatment or wasting resources. And to fully meet these goals, clinical and genomic findings should also incorporate patients' preferences for a shared decision-making. And we also need to ensure that findings are generalizable to routine practice by conducting implementation studies. So I'd like to acknowledge my co-authors and the funding I received, and a special thanks to Dr. Bernetsky for her support and leadership, and also to our team members. And thank you for your attention. I'll be happy to take any questions.
Thank you so much, Celline. That's wonderful. Kaberi has asked a question related to step 1. So if we look at the results where we looked at flare rate tapering or discontinuation versus maintenance, maybe go back to that slide. Okay. So Kaberi's question is, could it not be that they are tapering, the patients are tapering or discontinuing because it's not working, hence high risk of flare? So in fact, so here, let's think about this. So here we have, we're measuring factors at baseline, and then so at baseline is when the sort of decision is made. Let's see. So baseline is when people baseline is when the decision is made to either maintain, reduce, or discontinue. And then we follow them up, and it's at this is a limitation, but it's only at yearly intervals that we can ascertain the disease activity. But we do have information about hospitalizations, for example, in between the times, and then we have fairly accurate information about medication changes. So if a person has according to our flare definition, they're not flaring, our definition of a flare would have to be some increase in disease activity. So, Celline, I don't know, what do you think about Kaberi's proposition that we're tapering or discontinuing hydroxychloroquine because it's not working? I suppose we should take a step back and because we have this data in front of us all the time, we forget to mention that in lupus, usually this is kind of the background treatment. So people have this tendency since the 1990s to leave people on hydroxychloroquine unless there's some kind of reason to stop, either patient preference or toxicity or there's a number of different possible reasons, but there's a general tendency to kind of leave things as they are. If a patient were to be flaring, they probably wouldn't stop the hydroxychloroquine. They would probably add it, I would say. So that's probably the background that we need to make sense of this. Now, so Celline, maybe you can ask us if that makes sense to you, but perhaps you'd also like to comment on the reality of whether patients are going to be, in fact, stopping it themselves because they don't think it works, right? That could be part of the equation.
Yeah, that's what I thought, because one of the reasons, potential reasons, is to it's non-adherence, and I think one motive for non-adherence is this drug is not helping me, so I'm going to stop.
Yeah, that I guess that then from that perspective, from the physician's point of view, perhaps they don't think of themselves as stopping the drug because it's not working. Because there's this philosophy in rheumatology that these drugs are, should be maintained for a long part of a person's history. But Kaberi's point could be valid in that a patient who just doesn't believe it works, he's not.
Well, we really saw around 40% of patients had high disease activity at baseline. So for these patients, it's not that it wasn't working, but why did they have, while taking hydroxychloroquine, they still had high disease activity?
Right. So there were some people who something was going on. Some changes were made in hydroxychloroquine, but it wasn't necessarily that their disease was completely in remission. So Susan Bartlett has some relevant question here. So one of her questions is the definition of a flare. So I'll let you answer that. You may want to go back to your methods slides.
Yep. So you use you use it's a composite outcome. So we use the time to first flare. It could be the hospitalization, increasing disease activity, and therapy augmentation. So those are strategies they use in the clinical trials for indicator of a flare. And we did see also analyze each of them separately, but hospitalization was very, sorry, what happened? Okay, hospitalization was very rare, and therapy augmentation was the highest, was the most frequent outcome that happened.
So then Susan also asked if most patients who are tapering regain control of their disease by returning to the original level of the drug. And I guess we don't know. From your research, that wasn't something that we've looked at.
Okay.
Because it wasn't one of our outcomes, really.
Yeah.
But I guess, Celline, that might be something you may want to tackle in the future. So then we have a question from Santiago. Does Santiago just want to shout out the questions that he didn't?
Hi, can I ask the question?
Yeah.
Sure.
Hi, Celline, how are you? Nice to meet you. Very nice presentation. I have a few questions regarding the table 1 of the first step. I have the same feeling. I think maybe a colleague that they mentioned. It's very hard to assume that the risk factors are involved after the discontinuation of the drug, because I think we need to understand why a physician or a patient stop or decrease the medication or continue. So if we analyze why the physician is going to stop the medication or continue or decreasing, we're going to understand better, because maybe they're right. The physician is going to stop the medication because the patient already have some difficulties with the disease, or have like an increase in the disease level. So that's why they stop. So those patients, they're on risk because the disease was worse. So I think we need to understand why the physician or the patient stop the medication or decrease. And I have a question about I think it was the last one. You mentioned that you want to do a trial. I don't know if you can put the. Yes, here. So
would it be okay if Celline first answered the first question and then?
Yes, sure.
Go ahead, Celline.
Yeah, so that's a big limitation. We didn't have access to, in the database, there's no way to know what was the real reason. We just have a report if the patient stopped or reduced the dose. You have like the average dose took in the last year. But we assume the physicians, as Sasha mentioned, they wouldn't stop or taper if the patient wasn't doing well. That would be the contrary, like they would increase hydroxychloroquine drug or prednisone, but they wouldn't stop hydroxychloroquine and increase other drugs because the other drugs have more adverse events than hydroxychloroquine. So
now we have the, sorry, go ahead.
Yeah, so we imagined that if they stopped having a higher, being already in a disease activity, maybe their choice, maybe non-adherence or because of intolerance or allergy, something like that.
Okay, so you think that the main reason of stopping or decreasing hydroxychloroquine is because adherence or side effect?
If the patient were not controlled.
Yeah. So the bottom line is that we didn't collect the information. This is information that that all the cohorts in Canada have been collecting over the years. So you can't, in a cohort study, you can't always collect everything. There's some balance between what's kind of burdensome or feasible. So then we didn't have the exact reason for stopping of the drug, but Celline has done some very interesting analyses, which perhaps she'll be able to show you at another time. They're unpublished, so we have not presented them here. Celline didn't present them here, but we did try to drill down a little bit, and there are some indicators in the data that are fairly clear that a reason for the reason. So these would include, you could make assumptions, of course, but you could identify based on the data elements, which include like one element for damage, and that would include retinal toxicity. So we can pretty much separate out those patients who did have retinal toxicity, and that would have been an indication for discontinuation, for example. So working on that, plus some assumptions on things like, for example, times when there have been changes in these guidelines where everybody had to kind of bump down their dose a little bit. So that was another reason for change that we could flag within the data. And then there was another assumption made when people were having very stable disease, and that was kind of the classic context in which the patient and physician would likely taper or discontinue. So everybody that was left was left in a category of that this could be a discontinuation or taper due to patient decision or intolerance or something of that nature. So Celline has actually done some interesting analyses looking at that, and they kind of make sense. They're very interesting, but we weren't able to present them today. So now Santiago has another question on this part of it, I think.
Yes, I understand that the first division you randomize, and the second division is something that you intervene, or it's a patient or a physician decision, or it's made by the study, it's a randomization, the decision to maintain or decrease.
So in my understanding, it wouldn't be a randomization, and will be the intervention. Like we separate patients by subgroups, and based on their profile of preference and risks for flare or toxicity, we will choose which treatment they will receive.
So that's one way we could do it. We haven't made up our minds completely, but that is one way. So compare, if we just went on doing the same thing, which is basically, it's sad, that all the rheumatologists in the world are not necessarily making an evidence-based decision with the patient. We really don't know when to take these medications. So and in fact, we just recently had a teleconference with the Canadian rheumatologists who do lupus research, and we were saying, what's our next step? And even based on the data that we have, there were some people who would find it hard to randomize their patients to an intervention where even the patient would be allowed to choose to maintain or discontinue, because the physician felt it was their duty to keep them on that drug. So I thought that was very interesting. So we have another question from Susan.
Sorry, can I finish?
Yeah,
Just the last one, and that's it. In the second, you mentioned that you didn't have enough patients to see results, or like yes, this one. So you were able to calculate how many patients you will need to assume those results.
this is actually not. This is a second part, which is the retinal toxicity part. So we've actually, Celline's done some more analyses, which again, she didn't show you because they're not published, on the larger cohort. So I would say, I guess, going forward at this time, our plans for the pragmatic trial are mostly around the flare work. Although I think that this in combination with the work that Celline did on the prevalent cohort, where we had more cases of retinal toxicity, and in combination with the literature, I think if Celline shows you the Kaplan-Meier curve, even if we don't get great separation between distinct, risk factors like race, ethnicity, I think we can give people a fairly good bottom line on the fact that the risk for retinal toxicity is related to the chemotherapy and hydroxychloroquine. So that probably is going to ultimately be the biggest factor for patients and the physicians to be aware of. So I think that's kind of where I would go with the retinal toxicity part, as opposed to the flare part, where Celline was able to find more predictors.
Yeah, for the retinal toxicity, the number of outcomes was less than 1%. So maybe if we have at least 10% of the population, we could do more. But yeah, we're waiting for a longer follow-up, so we can take more patients.
But that could be
okay.
on the inception cohort. That could take 10 more years. So we're still thinking of positioning ourselves to do maybe something in terms of pragmatic trials sooner, but it depends on what.
Yeah, that's real. The other, we have some studies that conducted. They found some predictors, but they all used prevalent users of hydroxychloroquine. So patients were already in 10 years of use. And here we want to see in the beginning how that develops. So that's why we.
Yeah, that's a good point.
Thank you.
Thank you.
Okay, thank you.
So Susan also has a question about the patient preference studies we're planning or conducting. Susan.
So I love the work that you're doing. It's fascinating. We're doing similar work in rheumatoid arthritis around tapering of biologics and what the consequences are. And so that's why I had some of the earlier questions about defining a flare. In our work, we define flare as a major inflammatory event where you would have to change medication. Because the disease activity had clearly increased, but it took a long time to actually get consensus around that definition. It became even more important, I think, when we started to move and think about doing the patient preference studies, because we put together like the first mock-ups of our patient preference work. And we were asking patients about a 20% risk difference. So a 20% increase in the risk of having a flare, would you be willing to trade that versus say a 40% increase in the risk of flare? And then what came back from patients immediately was, well, but what do you mean by flare? Like how bad of a flare? Am I gonna have to miss work for this flare? Are you talking about in the next month? Are you talking about in 6 months? Are you talking about in the next year? So we found, and we're still struggling, frankly, with really trying to quantify, because I think it was easier for us as the clinicians and the researchers to think about it more abstractly, like, well, so your risk of flare increases 20%, but it was the patients who really grounded us, and we've got to be able to tell a story about what that looks like. So I just wondered if you guys have been struggling with that as well as you're moving into doing your patient preference studies.
So Celine, do you think it's harder to capture the details and the significance of a lupus flare or a rheumatoid arthritis flare?
Oh,
Because I agree it's a challenge.
yeah, I don't know. I think this is a really good point. I think the lupus patients may have the same kind of perspective. If it's a flare that would need hospitalization, then they will consider it a different risk of a flare. That is not that
Yeah, right.
severe.
Yeah. So then I think, so in fact, Glenn Hazelwood is working with Susan. That's correct, Susan?
Yeah, this is from his work, actually. This is from his paper.
Yeah, that's right. So in fact, so that's this is our first project using discrete choice experiment kind of methodology, and we haven't really delved into it yet, but everything that Glenn has learned from the project that he's working on with you, Susan, we're able to make some use of that. So it's really been good. I was actually thinking that we have worse of a problem in lupus because some people call it the disease of 1,000 faces. So certainly every rheumatoid arthritis patient has their own personal challenges, and every patient who is living with rheumatoid arthritis is different, is unique. But in lupus, I feel that sometimes we have that challenge is stepped up because we have so many different manifestations. That's why it's called the disease of 1,000 faces. So that's just my personal viewpoint, is that everything is harder in lupus.
And Sasha and Celine, how much agreement is there amongst rheumatologists when that a patient is flaring?
So there, it depends, I guess, in the end on the severity of a flare. I think for milder flares, it would be hard to pin down, especially now in the days of telemedicine. But there are probably better, I guess there's probably better biomarkers, because in RA, you're a little bit limited to either the physical exam or non-specific markers of inflammation, unless you're waiting for joint damage, which is too late. Versus in lupus, where you do have things like rash, which is a little bit more right in front of you. If you've got a really marked rash, that can be more obvious perhaps. But the other thing is our most severe forms, things like kidney involvement, would be quantified, quantifiable by urine tests. So I guess that's the side where maybe we do have we have maybe a little bit more ability to quantify some of those forms of lupus flares.
Yeah, maybe someday we should sit down and have a glass of wine together, because I might argue that you have it a bit easier because we rely on patient reports, or we were able to validate and come up with a system where patient reports became our ultimate thing around which we could make decisions around whether a patient was flaring and how badly they were flaring.
Right. And we've had that conversation before, right? Because in a disease like lupus, it can be silent. That's a scary thing, In RA, you can have, you can maybe pay more attention to the pain side of things, right? Or the dysfunction side of things, where the scary thing about lupus is sometimes that disease activity can be silently ongoing and be, causing kidney damage, and patients may not actually have that many symptoms, which is that's the scary part. So in some ways, maybe it's easy. In some ways, it's not easy, but it's always interesting, isn't it?
It's very interesting work.
And what I observe in the observational studies, they always use increases in activity as the flare indicator, because I think it's a scale, it's the SLICC 2K, and then it's easier just to classify patients flare or not, other than considering all the other causes.
Thank you so much. I don't know if anybody else has some questions. I was going to ask you, Celline, seeing as you've had different experiences in research, thinking about patient-specific characteristics and how they affect outcomes. If you look at some of the predictors of poor outcomes that tend to reappear time and time again in lupus literature, such as Black race or First Nations race ethnicity, if you've thought a little bit about what might be behind, so not specific to your study, but in general, as a pharmacist, as a researcher, when you see people of a certain race ethnicity with results that look worse, we'll say, according to whatever outcomes might be measured, what should clinicians and researchers be most aware of, do you think, or even as a practicing pharmacist, what should we all be thinking of when we see these patterns?
I think more inequalities of health. We hadn't have time to discuss this, but Black patients and First Nations, they have more difficulty accessing healthcare. Maybe there's some kind of prejudice within the care, and it's a chain of happenings that they first have this difficulty to get there, and so they're diagnosed at a more severe stage, and then treatment is not that effective anymore, and they are not they are less adherent because they don't have enough information, and so it's all connected. Their the race, education, income, I think all can. So yeah. I think we, as providers, we should pay more attention to these patients and say, why you're here, where you come from, and let's see your stage carefully, and this is the information you need to know, and let's follow in a more careful, way, more detailed oriented practice.
Yeah. There's many layers. There even the Canadian Rheumatology Association has programs now to try to help clinicians better understanding that the challenges that First Nations groups might face in accessing health care, or different things that we maybe have never considered as healthcare providers when it comes to potentially vulnerable groups like First Nations, that we really need to be educated as healthcare providers. Thank you very much, Celline.
Thank you everyone.